reason to believe on YouTube, because I have got messages on YouTube, I think, during this. I think they're from YouTube. They've got that little red thing on them. Anyway, hi, Alice. Nice to see you're here. You and me, girl. Alice and Albitas. There you go. 3 of us. Excellent. So, right then, what have we got? Well, I've got a question. Oh, listen, I feel bad now because there's 2 people on Instagram. There's no one on Facebook. And I've got a photo, which I can't get on Instagram. But don't worry, Alice and Albitas. I'm going to get it on just for you. I'm going to get it for you. So this is a photo. You may or may not be interested in this, but anyway, this is a photo. Why is my tattoo not suitable for excision? Now, miracles of modern science. I'm going to put the photo on my screen like that, right? And then I'm going to do this. Hold on a minute. Sorry, let me get this right. How can I? Can you see that? There's a light on it, isn't there? Is it this light? What light? Can you see that? Anyway, I don't know if you can see it or not, but anyway, it's a big. I think it's no. Actually, where is it? Oh, calf. So it's on the calf. Anyway, it's a big tattoo. Okay, it's a big tattoo on the calf. So, Khan's on Facebook. There you go. Hi, Khan. Nice to see you. So basically, it's a big tattoo on the calf, and it covers like. To be honest with you, it's quite hard to see where it is, but I think it's sort of below the knee, and it looks like it's almost the whole width of the calf, and that's just too big. Oh, Albitas, hello. I have a small tattoo on my wrist that could be removed with surgery and take care of the scar, so that is as good as possible. Thank you. So yeah, it's a very, very big tattoo on the calf, and the problem is there's not much spare skin on the calf. And if you think of it from our point of view, we're not going to be able to take that much skin away from the calf. And a lot of people say things like doing skin grafts, and skin grafts aren't good, particularly around a joint. This is around the knee joint. They're tight, they are unsightly. So in my view, a skin graft wouldn't be good. My view, Jackie's here. Jackie, where you been? My view is that I wouldn't do skin graft. If anything, I'd do serial excision, which makes taking a bit away at the time. But when you've got massive ones, it's just going to take ages. There's 3 or 4 months between each serial excision, and that's going to be like 7 or 8. What's that? Years. What's that? 3 years? 3 or 4 months? 3 a year? 3, yeah. So it's going to be years, basically. So I think it's probably easier just to say it is not suitable for excision. It's too big. It's just around the calf. It's around the knee. Laser would be my advice. Laser is always my advice, really, first line for tattoos. But there's color in this one, so I can understand if that might not be appropriate for this person. So yeah, but I think unfortunately not a good one for excision. I should really show you some good ones for excision, shouldn't I? Because the majority of the ones I see really are unsuitable because they're too big or they're in too bad an area. Got to be honest, the wrist isn't a great area. There's not much spare skin there either. Carol May has got a question. Hey, I'm a newbie to you, so I try and ask just little stuff at Mo. I desperately want breast implants and I'm in UK, but it's so expensive here, so going abroad seems my only option, but makes whole experience more scary. TBF. But anyway, what's TBF? To be fair? Oh, sorry, let's get rid of the tattoo. Sorry. TBF. But anyway, a main question for me is how long do implants last and how safe is this op long term? Like I've had 4 C-sections and been fine, but all I'm doing is thinking something bad will happen to me if I put my body through surgery again. What's your thoughts, please? Nice. Totally understand, Carol, about the abroad thing. I totally accept and realize that it is significantly cheaper abroad than it is in the UK. And I understand that makes it very attractive, and it is a huge industry, to be honest with you. TBH, it is a huge industry and is very popular for people to go abroad. I don't recommend it. You might say that's, you wouldn't, would you, mate? To be honest with you, Carol, I don't recommend it either way, because we sometimes see people who are in Europe, in France, Switzerland, Belgium, and also in other parts of the country, Scotland, parts of Wales and things which are quite far away, sort of North Wales. And I don't recommend people go a long way away for surgery, just in general, either way, whether it be people from here going there or people from there coming here. As a general rule, it's not great practice. It's not good to have any sort of, particularly going sort of airline travel around the time of surgery. You're going to increase your risk of clots in the legs and things. But particularly in terms of going to Europe, you've got to ask, why is the price so different? And one of the things I have realized, and it's hard to generalize because I'm sure that there are, variety of different providers everywhere in the UK and abroad. But one of the things I've realized is that one thing that certainly we focus on a lot is the aftercare. And I often get people on this Facebook and on the Instagram and the social media and things asking for help, they've got issues, they've got questions, and they're quite soon post-op. And my response is always, look, you should see your surgeon, really, because they're the ones who did it and they'll know exactly what's going on. And they're like, well, I can't get hold of my surgeon's not very responsive and things. So you've got to look at the aftercare. You've got to look at how they're going to look after you, because the way it works with plastic surgery and cosmetic surgery is you pay for what's called a fixed price package, which means all the aftercare is included with the price. You cannot just buy aftercare. So you can't have surgery out abroad for a certain price and then come back to the UK and try and get aftercare with a plastic surgeon in the UK. It's not just the way it works. You have the duty of care is with your surgeon. And so I have seen people being a bit frustrated trying to get help and trying to get advice, and particularly if you need further surgery, etc., it might be an issue. So that's just something to bear in mind. The other thing, and I talk about this in my book, Carol, you want a copy? You can have one. Yeah, that's the guide. Never Accept a Lift from Strangers. You can get it on the website, neveracceptaliftfromstrangers.com. We charge you postage passing, which is $3.95, I think it is. If you live near Edgbaston in Birmingham, you can drop into the clinic and pick one up. Is the training. The training is very variable, and so I can tell people in this country what to look out for: consultant in the NHS, FRCS PLAST, specialist register on the GMC, and it's hard enough finding a fully trained surgeon in the UK when we know about all the training. But the training in Europe and in other parts of the world, I wouldn't know how to tell you to find a fully trained plastic surgeon because I don't know what their training structure is. So those are the things in terms of going abroad. Oh yes, and the expensive thing. So yes, I think one of the things that we do focus on here in the UK is the aftercare a lot more, and I think you can't undervalue that. But also the clinics here in the UK, certainly we have quite stringent criteria in terms of infection control, in terms of clinical governance, in terms of insurance, indemnity. We have to be registered with the Care Quality Commission, and there's quite a lot of standards in place that will protect people having this sort of surgery. Are those standards in place in Europe and abroad? I don't know. I'm not saying they're not. It's just that I don't know, because I don't know if they've got an equivalent of CQC. They probably have, but you have to sort of research this and find out whether they've got this and what they've got in terms of insurance and safeguarding with infection control, etc. So those are the issues around going abroad. In terms of the implants, how long do the implants last and how safe is the op long term? A lot of people say they've got to be changed every 10 years. They haven't got to be changed every 10 years. Implants these days are made of what's called cohesive gel, which means they don't leak liquid silicone like the old ones used to. So they are much safer if the shell ruptures. They tend not to leak liquid silicone. So probably the most common problem you're going to have long-term with implants is capsular contracture, which is scar tissue forming around the implant. Now, having said they don't have to be changed every 10 years, they can start to go hard around 5 or 10 years, and you might want to have them changed around 10 years. So, you might want to have them changed around the 5 or 10 year mark. but they can last longer. And there are different types of implants. There are smooth implants, which go hard a bit quicker, and there are polyurethane foam implants, which go hard slower. They take a lot longer to go hard. So depending on the type of implant you have, you can get implants which last longer, which are the foam ones. The flip side of that is there's a cancer associated with implants called ALCL. It's very rare and it's curable, but it's a cancer, and it's obviously a worry, and it seems to be rated how rough the implants are. So the rougher the implants, the less likely they are going hard, so the longer they'll last in that respect. So the polyurethane ones are sort of very rough and they last longer in that respect, but they've got a higher risk of the ALCL, which is a cancer, whereas the smooth ones have got don't really get the ALCL cancer, but they're much more likely to go hard. So there's things to think about in terms of the surgery, and there's no question there are risks with it. Having said that, the risks are very low, they're very rare, and it does improve people's quality of life, and it does deliver very high satisfaction rates. So what I normally say to people, Carol, is it's up to the individual to weigh up whether it's worth taking on the risks versus the benefits they're going to feel by having implants. So if they're going to feel huge benefit from having implants, they might accept the risks. If they're not going to have that huge benefit of having implants, if they're not sure whether they want it or not, and you start telling them about capsular contracture, ALCL, breast implant illness, all the things that can go bad with implants, then they might say, actually, you know what, forget it. So it's actually a balance between the risks and the benefits. And the benefits only you can know, the risks we can tell you, and then you can make your own decision on your own judgment on whether where you're sitting on that balance. But it's as I say, very popular procedure, very high satisfaction rate, very low complication rate. But it's important that you're aware of all the potential risks and complications that can be associated with the surgery. Thanks, Carol. Nice to have you on board, and I hope that's been helpful. Sophia is in the house. Hi, Sophia. And Sophia says, I have a consultation on the 21st. When's that? A few weeks. I'm really looking forward to my journey. Nice. Good luck, Sophia. I don't know if the consultation is someone else, but if whoever it is with, good luck. And if it's with me, looking forward to seeing on the 21st. Can't wait. So is it me, or is the text of this sort of, it used to scroll, but anyway, hide. Anyway, never mind. We'll work with it. Edit. Oh, I can edit it. Apply. Anyway, can you go ahead with GA or LA surgery when pregnant? Well, I would be wary, and I would wonder why you're having surgery. And a GA, I would say, well, let me think about this. So you can, but it wouldn't be advised. So if you have appendicitis, for instance, or bowel obstruction, or I don't know, some really bad problem, then maybe again, risk and benefit again, isn't it? And now most of cosmetic surgery, which is sort of what I do, well, I say most, all of cosmetic surgery is not really urgent. So in that case, I would advise against it if you are thinking of having it, because the certainly GA, that's for sure. So general anesthetic. So the drugs we give with general anesthetic are you just wouldn't want to have those drugs because I'm not an anaesthetist. We'd have to talk to the anaesthetist, but that you wouldn't want to have any harm to the unborn child. So I think if it could wait, let's just say it should wait. Local anesthetic, again, I think a lot of people don't like anything, do they? People don't like taking paracetamol when they're pregnant. So I probably wouldn't have a local anesthetic even if I was pregnant, even a local. I guess if you fell over and cut your face, you could have it stitched up under local anesthetic. But if, for instance, you've got a mole on your face, now moles often go darker during pregnancy anyway, so people do sometimes worry about moles during pregnancy. I guess if you're really worried that it might be a melanoma or a nasty skin cancer, you might think about taking it off. But as a general principle, I would say I would advise avoiding surgery when you're pregnant. And I think most pregnant women do not want stuff, drugs, sort of medication and things like that. And certainly I think GA would be advised not to have it if you could put it off. LA possible, but again, if you could put it off, I probably would suggest that you put it off. Sophia is with me. Well, there you go, 21st. I've got the date in my diary. Sophia, I am counting down the days. Carol, thank you, very honest. Thank you. Double thumbs up. Thank you for that. Jade, how? Oh, here we go. Two-part question this. How? Second part, how long do you have to maintain weight before any kind of surgery, etc., tummy tuck or breast lift? There's no rule, Jade. In the private sector, there's no rule, and it's surgeon specific. There's no sort of guidance. Often in the NHS, you have to sort of maintain weight for 6 months or 12 months or 2 years sometimes before having surgery. But there's no hard and fast rule in the private sector. And what I try and do, Jade, is I try and have a partnership with the patient. So I try and explain that rather than me saying to you, you've got to have a stable weight for 6 months before having surgery, you've got to be true to yourself. And I know people often want the surgery as soon as they can, but you've got to be true to yourself because you want the best result you can get, obviously. And you're going to get a better result if you can maintain the weight. And things like tummy tuck and breast lift are expensive operations. They're not cheap. And if you put on weight after surgery or lose weight after surgery, you're going to affect the result of your surgery. You're going to have a better result if you had maintained the weight. So you really want to give yourself the best chance of getting the best result. So if your weight's high and you want to lose weight, then you're going to get a better result because you're going to have more spare skin. So your breast lift or tummy tuck might be required more because you have more skin if you lose weight first. And also your complication rate is going to be less if you can get to lower weight. And similarly, you don't want to sort of force yourself to get to a low weight to have surgery and then put weight on, because you're going to put weight on your breasts and your tummy and you're going to stretch the skin again. So you don't want to lose weight or put on weight after surgery. So it's normally a conversation, Jade, with you to say, look, you need to be stable and comfortable with your weight as much as possible before having any surgery to give yourself the best result. Zoe, can I lose weight after breast augmentation? You can, Zoe, and I understand that people have to live a life. So it's all very well me saying to you, you've got to be at a stable weight before having surgery. You might say, well, I don't know what's going to happen next year or 5 years or 10 years. And you know, obviously people lose weight and put on weight all the time. The problem is, Zoe, it's unpredictable. That's the problem. I don't know what's going to happen if you put on weight. Sometimes people put on weight and it all goes on their breasts. Sometimes none of it goes on their breasts. So you might have surgery now to have breast augmentation to have the size you want to be, and then you might put on weight and they might go on your breast and they might be too big then. As I say, it might not. It's just unpredictable. And you're better off, if you can, when you do surgery, have it on as predictable a playing field as possible. God knows this surgery is as unpredictable enough as it is without the added issue of weight fluctuations. So you can lose weight after breast augmentation, but it might affect the result. It might not, but it might. And probably no, I wouldn't say it's the worst thing you can do, but a really bad thing you can do, Zoe, is put on and lose weight. Because if you put on weight, it makes them bigger, and if you lose weight, it makes them smaller, but the skin doesn't retract, and so you're left with skins, and then they can droop. So putting on and losing weight is the sort of, you know, the real problem. Putting on weight in itself isn't so big, it isn't so bad. Everything gets bigger, you know, and everything you might think, oh, okay. But then if you lose weight, then your breast can droop. And if you just spent loads of money on a breast augmentation, you might not be happy. So, Louise, what's the smallest cc breast implant, please? I don't know, Louise. Hold on a minute. Right, first book that comes to hand. I mean, obviously different companies. This is a Nagel catalogue. Smallest is a 150. That's quite big actually. I'm sure others do smaller. Right, so look at this one. This Polytech catalogue. What's the smallest here? Smallest Polytech is 55 cc. So there you go. You know, that's it's a special order on a 6-week wait. 110 is the smallest sort of standard. So yeah, 55 is the absolute smallest. Louise, I hope that's been helpful. in Polytech. All the different companies will have different ranges. So yeah. Feel free to expand on that question if there's anything more I need to say about the smallest breast implant. Zoe, thank you. I lost weight before breast augmentation in September 2020 and since put weight on and want to lose it again. Oh dear. Okay. I mean, the thing I'd say to you, Zoe, is don't be too disheartened by what I've just said, because you might be okay. Everybody's different. Sometimes people don't put weight on their breasts. So so you lost weight before the breast augmentation, since put it on and now want to lose it again. Yeah, I mean, that's the worry, Zoe. Certainly with significant weight fluctuations, you worry that the skin will be stretched and might droop. I'm not saying it will. It's just a you know, it might. But let's be positive. Let's what do we call it? Not visualize, manifest. Yeah, manifest it to be okay. That's what you need to do. Jade, would you say a breast lift or implants would be better after weight loss? Sorry for the amount of questions. I'm new to all this. Jade, you don't have to say sorry. That's what we rely on. Is the oxygen for this. It's the bread and water for this questions. Jade, people get themselves tied into right old knots about all this breast lift and implants thing. Terrible knots about it. Broadly speaking, let's keep it simple, shall we? I mean, let's boil it down to the nubbins of it, right? This is the nubbins of it. Is it the shape or the size or both? Yeah. If it's the shape, i.e. they're droopy, then it's a lift. If it's the size, then, well, if they're too small, then it's implants. So implants make them bigger. A lift makes the shape better, but doesn't do anything to the size. There you go. That's it. Simple as that, Jade. So is it the size or is it the shape? Now, it might be the size and the shape. So if they're too small and they're droopy, then you can have a lift and implants. Or, as I say, if it's the size of the shape and they're too big and they're droopy, then it's a reduction. But broadly speaking, people often think, should I have implants? Should I have a lift? I'm like, well, what size bra do you wear? They say, I wear a 34D. I'm like, well, what size do you want to wear? Well, I'm happy being a D. So what's the problem? When I take my bra off, they sit, well, that's a lift then, isn't it? You know, what size bra do you wear? 32B. What do you want to wear? Double D. Oh, well, it's implants then, isn't it? Because you want to be bigger. Sometimes it's a combination. Now, it's not quite as simple as that, but I think that's quite a good way to think of it, to be honest with you. I think if you think of it like that, you won't go far wrong. But the reason it's not quite as simple as that is because a lift, sometimes I make it clear to people the sort of shape you can get with a lift, because it's not quite as full in the upper part as you can get with implants. And sometimes people want fuller up there, and so they want implants for the fullness. But then you get into difficult waters when people want the implants for the fullness, but they don't want to be bigger. So then you get into swampy waters, not swampy, you know, into difficult territory. Swampy waters isn't a good thing to say, but you know, it's a tricky one, that when people are happy with the size but want that fullness that you get with implants. I'm like, well, you know, really it's just a lift, I would say. And anyway, we could go on about that all night, Jade, but that's basically it. Are they big enough? If they are, lift. If they're not, implants. And it might be that the shape, you might need a lift and implants if they're droopy and they're too small. Simple. So what's the fuss? Simple, isn't it? It's not that difficult, this job. Well, the job is difficult, but the decision making isn't as difficult as I think patients make out. But no, the job, I wouldn't say the job isn't that difficult. Louise, you're very welcome. Smallest CC, best implant, you're very welcome. Jade, would be both. Well, there you go. If it's shape and size, then a lift and implants. Big deal, a lift and implants, so Jade. And I often say to people, if they're borderline for one, you can split it and do what the lift or the implants and then do the implants or the lift. Some surgeons routinely split it. I do it all in one, but, you know, it's a big deal doing a lift and implants. Emma Lou, hello. I'm not sure what that emoji is. Waving, is it? Or clapping? Or I don't know. Anyway, hello. When I have my consultation, will you be able to give me an approximate date that I will have surgery, please? I have work commitments, so I weren't sure if I could give certain weeks and months that I can book off work. Thank you. Yes, Emma. It is tricky. I've got to be honest with you, Emma. I'm going to be full disclosure with you now, Emma. It is tricky in terms of the dates. I do believe we do have dates that we can give you dates on the day of your consultation. But at the same time, if you have specific dates and we can't give you those dates, there might be a situation where we might say we'll have to get back to you, because we are the hospitals are most of the hospitals are being used by the NHS, and they're releasing dates to us when they can give us dates, and sometimes, you know, it's a bit sort of ad hoc. It used to be a lot more sort of scheduled. My practice used to be like every Monday and Tuesday I was doing surgery, and that we all knew where we were, and you could book a date, you know, weeks, months in advance, and we could book you in no problem. But these days we've only got limited dates for surgery, and then we're getting them as we can. It is getting better though, Emma. I think it is getting better. But so the answer to that is, I hope we will be able to give you a date that's suitable to you when you come, and we will try to. But, you know, let's just hope it. Yeah, just say yes. Yeah. Carol May. God, I hope I get to talk to you if I go for this. I feel more relaxed and worried already. I want to look like a woman like now, lol, but I'm just so bloody anxious. Yeah, you feel more relaxed and worried. Okay. Yeah. Well, Carol, yeah, you can talk to me. Here we go. Here we are. We're talking. Got to be honest with you, Carol. You got to be honest. You got to realize that there are bad things that can happen when you do breast implants. Having said that, they're extremely rare, so I wouldn't let it sort of overload you. But if you, in a way, this might sound bad, you know, if you can be put off, then that might not be a bad thing. So I do tell everybody all the bad things that can happen. I say I do. I think we all should, really. All doctors should. So if people aren't telling you about capsular contracture or breast implant illness or ALCL, you know, it's not really good practice. You should be aware of all these things, because they are factually happening in the world somewhere. You know, these issues are occurring. So yeah, good. Well, I'm glad you feel more relaxed. Not sure about the worried bit, but hey ho, kind of everything. Jade, thank you, Jade. Emma, that's great, thank you. See you Friday. Look at that. See you Friday. Look at that. How exciting. Who had it on the 21st? Someone's got it on the 21st. Sophia's got it on the 21st. Emma's got it on Friday. Look at that. God. I'm going to shave and I'm going to get my suit on, Emma. Well, I'll put my suit on, but then I have to wear the scrubs. I will tart myself up a bit, Emma, for Friday. Looking forward to it. Here we go. Here's a question. Why do I need steroid injections after keloid removal? Niche question, that, isn't it? Niche question. I'm sure a lot of you are sitting there thinking, what is he going on about? So I don't know if you know what keloids are. Keloids are sort of big lumpy scars. The problem with keloids, they're difficult to treat. Keloid scars are difficult to treat because the reason you get a keloid scar is because it's the way your body scars. Your body has an inappropriate reaction to scarring. They're often from an innocuous thing like an ear piercing or an injection for the BCG or something, or some innocuous thing, and it creates this very red, raised, florid scar from a tiny little pinprick. So therefore, they're difficult to treat because a lot of people come with these big keloid scars and they think, oh yeah, cut that off, please, mate. And you're like, well, hold on a minute. You've got that from an ear piercing, from a dot. An ear piercing is a dot. If I cut them off, I'm going to give you a scar like that. So if a dot's gone to that, what's that scar? It's going to go to even, you know, it's going to exponentially up and be worse than the flipping dot. So that's why we worry about cutting out keloid scars. And actually, it's depending on how big the scar is, it's sort of a last resort to cut them out because you run the risk of making them worse. Because if the problem is the way your body scars, we haven't modified that. We haven't cured you of that problem. That's a problem with you. God knows they're in the lab and, you know, investigating and researching keloid scars and trying to work out why they happen and trying to see if we can modify your body's response to stop you from causing keloid scars. But that's not where we are. We're not there yet. We don't know why they happen. There's no animal model for them. And there's a lot of research being done on keloid scars. But at the moment, we're stuck with the fact is you form keloid scars. So we're very wary about doing surgery on you because we don't want to give you another keloid scar which could be worse than the first one that you've got. So that's the first thing. But sometimes they're so big, these big ones on the earlobe and stuff, that you say, right, you've got to do an excision. and cut them off. And what we do when we do that excision is we do what's called an intralesional excision, which is sort of like a debulking. So you sort of take like taking a slice of cake. So you leave a rim of keloid behind. You're cutting into keloid. When you're making the cuts, you're cutting into the keloid scar, and you're leaving a rim of keloid scar behind. You're not cutting normal skin. So you try and you don't cut normal skin when you do an intralesional excision of a keloid scar, and then you're stitching keloid to keloid. And the fact that all your cuts are in keloid means you're less likely to form another keloid, because you're not cutting into normal skin, you're cutting into keloid scar. So therefore, when you do an excision of a keloid scar, you're left with a rim of keloid, you're left with a residual bump of keloid. And to get rid of that residual bump of keloid, then you use steroid injections. So steroid injections is a treatment for keloid scars, but when they're massive, you think that's not going to, that's what's the way of putting it? But that's not going to make an effect. Steroid injections into a really big keloid. So if you can debulk it and make it into a smaller keloid, then you can try and get rid of that residual keloid with steroid injections, which are an anti-inflammatory, which will dampen down that inflammation, which is potentially causing that keloid. So that answers your question. Why do I need a steroid injection after keloid removal? Well, that, my friend, is the reason why. Jade, what you got to say, Jade? Would you need to have your implants changed every few years, or would they last forever, if that makes sense? But somewhere in between, Jade, that does make sense. So sometimes there's a sort of thing that goes around saying they've got to be changed every 10 years, but they haven't. The main reason for having them changed is them to go hard. And I normally say to people, it takes about 5 or 10 years for them to go hard. So if you're having implants, you have to be aware that they might go hard and you might need to have them changed. There are different types. I wouldn't say they last forever. I think they may well, and going hard is probably the main problem you're going to get with them. So they may well go hard. Having said that, you don't have to have them changed. If you're happy with them going hard, or you don't want to have them changed, that's fine. You don't have to have them changed. It's called capsular contraction. It's just scar tissue. It's your body's scar tissue around the implant. So if you don't have to have them changed, but they can get uncomfortable. There are different types of implants that you can have, like polyurethane foam ones, which are less likely to go hard, or at least take longer to go hard, but they're more associated with the ALCL, which is a type of cancer associated with implants. So a lot of people don't fancy those. Very rare, treatable, but still understandably don't fancy those. So they'll go with the other types, which aren't as rough. And so the less rough they are, they're more likely to go hard, but the less likely they'll get capsular contracture. So there's a balance to be had when you decide what type of implant. There's a range of implants available. Some go hard quicker than others, but the ones that go hard slower have other risk profiles associated with them. So you have to decide where you want to go in terms of which implant to have. But broadly speaking, whichever implant you have, there's a risk that you might need to have them changed at some point in your life, particularly if you're young. I wouldn't say they'd last forever. Do you do umbilicoplasty procedures? Got no context for that. Don't really know what that... So basically, umbilicoplasty just means changing the shape of the umbilicus. The umbilicus is your belly button. So do I do changing belly button shape procedures? Yes, I do. So I guess the answer is yes in that case. Yeah, I do. I mean, often with a tummy tuck, you're creating a new belly button, and maybe that doesn't look quite right. You can do an umbilicoplasty to change the shape of it. Sometimes you can lose a belly button. It's a rare complication of a tummy tuck. Some people are born without belly buttons, or they've got anterior abdominal wall problems. So sometimes we need to recreate a belly button in someone who hasn't got one. That would also be called an umbilicoplasty. So so changing the shape of a belly button or recreating a belly button if you haven't got one, yes, that would all fall under the umbrella of umbilicoplasty, and that is something that I and plastic surgeons do. Yes, it is. Do you carry out 360 lipo? Well, that's a Nicole. Well, do you do lipo? Yes, I do liposuction. What do you mean 360 degree? Do you mean, obviously, well, not obviously, 360 degree liposuction all the way around your body? You could do that. I probably, the problem with doing 360 thing, Nicole, is particularly if you're asleep. If you're awake, if you do it under local sedation, you might be a bit easier on the turns. But it's turning people when they're asleep is a bit of a is a bit of an ordeal. So try and avoid turning people. So I'll be honest with you, Nicole, I would avoid doing liposuction on the front and the back. I would probably just do liposuction on one or the other, and it's usually the front that's the problem. So I wouldn't do 360 liposuction, particularly 360 degrees tummy tuck. Maybe that's a tummy tuck that goes all the way around. But to do so, maybe what you're asking, Nicole, is am I one of these people who do these sort of massive liposuction? Some people do massive, 5 liters big liposuction. No, I don't do massive areas of liposuction. For me, liposuction is usually combined with tummy tuck to hit the hips and the sides. I don't personally. I don't find that you can get, huge, significant body contouring with liposuction alone in my hands. I know people do it, but what problem is you don't get significant skin retraction. So, for instance, the anterior abdomen, I don't find that I get very good results from liposuction on the anterior abdomen. On the sides, yes, the skin recoils better, but the anterior aspect of the abdomen, no, the skin doesn't recoil very well. So, for me, the best way to do that is with a tummy tuck. So I would probably be I'm more of a tummy tuck combined with liposuction person rather than sort of 360-degree liposuction. On the other hand, skin tag removal, yes, I do that. Right, thank you. That was a dog. Thanks for that. Yeah, the dog's agreeing with that. So yeah, we do, don't we? Yeah, we do skin tag removal. Yeah, skin tag removal is a yes. Carol, that's Jade. Sorry, Carol's got the next question. Myself called you the wrong name. Jade, sorry. It's the dog. It's not my fault. It's putting me off. Nicole says, yeah. She's shouting about. Thank you so much for your help. I think the padded bra is going to be my thing for a while. However, I do go ahead. I'm calling you. Oh, well, there you go. There you go. Carol's going with the padded bra. You go, Carol. Go with the padded bra. So much less complications with the padded bra, honestly. No scar, much cheaper. That's it. In fact, we got these things in the clinic, sizes where you put in your bra to give you an idea of volume. And we've been talking about this for ages. It's one of those things where you talk about. Why don't we just sell them? Why don't we just sell the sizes? I think life would be a lot easier sometimes if we just sold the sizes, but getting them branded and all that. Anyway, but yes, Carol, padded bras not such a bad plan. Am I allowed to bring my 4-year-old to the appointment? Yeah, we had a thing the other day with someone who had children. I mean, the thing about children is we cannot allow unsupervised children in the clinic. We don't treat children in the clinic. That's something we decided a while ago, just in terms of the CQC and the governance around treating children. So we don't treat anyone under the age of 18. But I understand that sometimes people will bring children to the clinic if they're coming for an appointment or something. But you can't have a child unsupervised. So unfortunately, we can't have if you are going to be having a procedure or something, then you would need to bring someone to supervise your child while you have the procedure. So yeah. Do you do any reconstruction work, or is it primary cosmetic surgery at your clinic? It's primarily cosmetic surgery at the clinic. I mean, I used to do a lot of reconstructive work, and I actually spoke to someone the other day for a breast reconstruction because she'd been waiting so long on the NHS. So I can talk about breast reconstruction, but I've got to be honest with you. What I say to most people, if you're not insured, breast reconstruction is a very expensive thing to do self-pay because you have to pay for every operation. Whereas with cosmetic surgery, they've got packages. So if you have any complications, any problems, it's all included in the package. But for reconstruction, it's not. So, that can be an issue if you're having reconstruction privately. So I normally say the NHS does do it well, or obviously private insurance. So it's primarily cosmetic surgery at the clinic, although my background is breast reconstruction after mastectomy after cancer. What makes a mole eligible for just a shave rather than full surgical excision? So two criteria for a mole to be eligible for a shave. One, it has to be clinically benign, as in when we've examined you, we're not worried that it's anything cancerous. If there's anything cancerous, we would take the whole mole out and do an excision. So it has to be clinically benign and it has to be raised. You can't do a shave on a flat mole. So it has to be raised above the level of the skin. So if it's raised above the level of the skin and it's clinically benign, it will be eligible for a shave or an excision. Even though those two criteria are met, some people still might want an excision, which is fine. You've got an option of having an excision or a shave if it's raised and clinically benign. If it's not raised, if it's flat, or if we're worried it's a cancer, the best bet is to have it cut out and stitched up, linear scar and stitches and stuff like that. But if it is raised and benign, then a shave might be an option because the sort of volume of scarring with a shave is slightly less than with it's not an obvious scar, it's just a patch. So you might want to have a shave. I have a blue mole. Should I be worried about it? I'd rather not send photos. Not in itself. No, a blue mole or a blue nevus in itself, there's nothing to worry about. A blue nevus is just the pigmented cells. The melanocytes are a bit deeper in the dermis, giving it this blue look. So in itself, a blue nevus is not anything to particularly worry about. But if you have a mole, if you've had it for a long time and it's not changed, and the fact that you're using the term blue mole presumably means you've seen a doctor for it, then that's fine. I wouldn't worry about it as long as you've had your mole. I think if you are asking the question, you should have it looked at. Excuse me. You should have it looked at by someone. But if you've had it looked at and it's benign and it's not changed, then no, that's fine. And if you don't want to send photos, that's fine too. But if you're asking, you can't mess about with moles. So if you're asking the question, should I be worried about my mole? I'd be like, well, without even saying, you should get it looked at. Just go to your GP, get it looked at. Because once they've looked at it, they can often say, oh yeah, that's fine, or that should be looked at. You can't mess about with moles. Skin cancers are rare, but they're out there. Certainly the bad skin cancers like melanoma, the one we worry about, they're not common. So I don't want to worry you, but you need to. It's a bad thing when it happens. So you need to be careful. I've lost it. I'm on my last question. I don't know if I'll survive. I think I'll make it through the last question, but don't let that stop you. If you've got a question, this is the last question, guys. Are stretch marks common in breast augmentation patients? No. Well, not in my patients anyway. I think I'm right in saying we were talking about this the other day. That's probably why the questions come up. I think I can remember 3 patients with stretch marks. Definitely 2. I think 3. It's not common, and I think I try not to. I'm not the guy that puts in big implants. I'm not a guy. If you want really big implants, I always respect the boundaries of your breast. I won't go outside the borders of your breast. So I'm not one of these people who will put in 800cc implants or 1000cc or 1500 cc's. That's not really my thing. So I wonder, I don't know if you do put in bigger implants, I would imagine that it might cause more damage to the skin, which is basically what stretch marks are. So it can happen. As I say, it's not unheard of. There are, I have got some patients with stretch marks, but not many, and it's not a common thing. So it's not something sort of high on my list of worries. I know I put Carol off having surgery, so there are other things I would worry about. Capsular contracture, ALCL, breast implant illness, things like that would be probably higher on my list than stretch marks. But still, it's a thing, so it's probably something you should put into the mix if you are thinking of having implants. Whoa, that was emotional and intense. So I hope that's been helpful. If you've got any questions, feel free to speak now or forever hold your peace. No, not forever hold your peace. Hold your peace for a week, because I'll be back here. Will I? Yeah, next week, Tuesday, 7 o'clock, right here, for more of the same. And so feel free to get in touch. Message me on Instagram, Facebook, call me, email me, info@staianoplasticsurgery.co.uk. call me 01214543680. Don't forget to subscribe to my YouTube channel. Staiano Clinic, I think it's called. I don't know why I said that. Hold on a minute. Has Jade come in with a question? Wait a minute. I think we've got a question. Carol, Jade's coming in a last minute question. When having come back, everyone, both of you, come back. When having a tummy tuck, do you have to have drains in? If so, how long for? Jade, you don't have to have drains in. I do use drains. It's what we are generally using less drains in terms of surgery, and tummy tuck is one of the last bastions where drains are still used. There are people who don't use drains, so you can do tummy tucks without using drains, but it's one of the operations. So tummy tucks and big breast reductions, basically the two operations where I still use drains. So I do use drains. How long? You don't go home with them. So usually I would say one night for the drains, and then they come out and you go home. So you don't go home with the drains. They come out before you go. I still do use them because I worry about that space there. So they're suction drains. They're under negative pressure to remove any fluid to help that space to stick down. But there are very reasonable techniques that are being used that don't use them. And maybe one day I'll stop using them, to be honest with you, because patients don't really like them. But having said that, it doesn't increase your length of stay, because I think you're probably going to be in overnight anyway, because it's quite a long operation. Maybe not. Maybe you could go home the same day if you didn't use drains. But anyway, whatever. I do use drains, yeah, but not everyone does. And it doesn't mean they're right or wrong. It's just everyone's different experiences. Jade, thank you for that last minute question, Jade. Very, very grateful to you for participating. I am going to have a lie down on a glass of water because my water's finished. No, it hasn't. It is now. And I'm going to reconvene. Same time next week. Hope to see you there. All in fair warning, stopping the stream.